Cardiac output and hemodynamic review. Cardiac output is 48 liters a minute. It's the volume of blood pumped by the left ventricle each minute, and it's important for adequate tissue perfusion. To calculate cardiac output is heart rate times stroke volume. Cardiac index is the cardiac output adjusted for body size. It is the more precise measurement of the efficiency of the pumping action of the heart than cardiac output. Central venous pressure is 2 to 6 millimeters of mercury. The CVP is the right ventricular preload or right ventricular end diastolic pressure under normal conditions. It is measured in the right atrium or in the vena cava close to the heart. CVP catheters can measure oxygen saturation of hemoglobin in venous blood. The mean arterial pressure is calculated using the formula systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. What affects cardiac output? That would be the heart rate, altered contractility, reduced or excess preload, reduced or excess afterload, stroke volume, and dysrhythmias. Stroke volume is 60 to 100 mL. It is the volume ejected leaving the left ventricle with each heartbeat. High stroke volume is seen with bradycardia and exercise and with the use of positive inotropes such as dopamine. Changes in stroke volume are becoming more important indicators of the pumping status of the heart. Stroke volume index is adjusted for body size. Systemic vascular resistance index, stroke volume, and stroke volume index can be calculated when cardiac output is measured. Normal systemic vascular resistance is 800 to 1200 dynes per second per centimeter. SVR, or afterload, is the pressure of the heart pumps against to get the volume out to the lungs or the body. If that pressure is increased but volume, measured by the cardiac output, stays the same, it means the heart is working harder to get volume out and the blood pressure will go up. Since the heart is working harder, blood pressure will not decrease immediately. The blood pressure would increase initially in response to the increased workload. If treatment is not initiated, the heart will eventually tire and a decrease in blood pressure would be expected. With diuretic use, the systemic vascular resistance could normalize. Decreased SVR, you would see vasodilation and shock states and drugs that decrease the afterload. Increased SVR is vasoconstriction from shock, hypertension, increased release or administration of epinephrine or other vasoactive inotropes, or you could see it in left ventricular failure. Preload is the volume of blood within the ventricle at end of diastole. As preload increases, the force generated in the subsequent contraction increases, so stroke volume and cardiac output increase. Right ventricular preload depends on the volume returning to the right atria. Preload is increased during hypervolemia and ventricular failure. Preload is measured by the CVP, the RAP, the PAWP, and the PAOP, the pulmonary artery occlusion pressure. Preload is decreased during vasodilation or hypovolemia. Administering a 500 ml normal saline fluid bolus would be expected if preload were low. So a quick review of the initials. CVP, central venous pressure. RAP, right atrial pressure, and PAWP, pulmonary artery wedge pressure. Afterload is the forces opposing ventricular ejection, which is the resistance offered by the aortic valve. Afterload is the resistance the ventricles must overcome to eject the blood. The right ventricle is affected by pulmonary vascular resistance. The left ventricle is affected by systemic vascular resistance. Reduced afterload lessens the cardiac workload, and excessive afterload strains the ventricles and increases oxygen demand. Oxygen saturation of blood from the PA catheter is termed mixed venous oxygen saturation, SVO2. Similarly, O2 saturation of venous blood from the CVP catheter is termed central venous oxygen saturation, SCVO2. The SVO2 and the SCVO2 reflects the balance between oxygenation of arterial blood, tissue perfusion, and tissue oxygen consumption. Normal SVO2 and SCVO2 at rest is 60 to 80%. Observe for changes in arterial oxygenation through monitor of the pulse ox or ABGs, and indirectly assess the cardiac output and tissue perfusion. This is done by noting any changes in mental status, strength and quality of peripheral pulses, capillary refill, urine output, skin color, and temperature. An increase in SVO2 and SCVO2 may indicate clinical improvement such as improved arterial oxygen saturation. In sepsis, O2 is not extracted properly at the tissue level, resulting in an increased SVO2 and SCVO2. A decrease in SVO2 and SCVO2 could mean decreased arterial oxygenation, low cardiac output, low hemoglobin level, or increased oxygen consumption. Contractility is directly influenced by preload. The greater the stretch, the more forceful the contraction. The force of the cardiac muscle can be increased by sympathetic nervous system stimulation with positive inotropic medications. Increased contractility results in increased stroke volume and increased myocardial oxygen requirements. Meds that improve or increase contractility are termed positive inotropes, like digoxin, calcium, amiodarone. This also includes catecholamines such as dopamine, dobutamine, epinephrine, isoprenaline, and norepinephrine. Phosphodiesterase inhibitors like milrinone and amrinone. Contractility is reduced by negative inotropes. Examples include certain drugs like calcium channel blockers, beta-adrenergic blockers, and alcohol, and clinical conditions such as acidosis and hypoxemia. Chronotropic affects the heart rate via the SA node. The heart rate then is increased with positive chronotropes like atropine, epinephrine, isoproterenol like isoprel, dopamine, digitalis, and milrinone. The heart rate is decreased with negative chronotropes, and examples are beta blockers, acetylcholine, diltiazem, and verapamil. The CVP catheter helps monitor fluid status and return, and the trends are more important than a single measurement. The normal range for a CVP or right atrial pressure is 2 to 6 millimeters of mercury. Look for changes in pressure and assess for related physical changes. Monitor the CVP and level and zero the transducer every shift and as needed. Potential complications include infection, air embolus, and pneumothorax. Identification of the phlebostatic axis. It approximates the level of the right atrium and is considered to represent the level of the catheter tip. Trendelenburg position, or the head down position, may be used during insertion of the catheter to make visualization of the jugular approach easier. However, supine is the recommended position for hemodynamic monitoring. The zero reference point must be repositioned with changes in backrest elevation to keep it at the phlebostatic level. To do this, open the reference stopcock to room air, which is off to the patient, and observe the monitor for a reading of 0. This allows the monitor to use the atmospheric pressure as a reference for 0. Zeroing is done during initial setup of the monitoring line, such as arterial, CVP, or PA catheter, when the transducer has been disconnected from pressure cable, or the pressure cable has been disconnected from the monitor, or whenever accuracy of the values are questioned. Zeroing is done because the transducer position directly affects accuracy. Repeat the leveling and zeroing process every time the patient, the pole, or the bed is moved. In order to overcome arterial pressure and prevent blood from backing up into the pressure tubing, a pressure bag is placed around the flush solution and should be inflated to about 300 millimeters of mercury. Injectate can be either iced or room temperature normal saline and can effectively be used to obtain accurate cardiac output measurements. The traditional method of thermal dilution cardiac output uses a 10 ml bolus of injectate. A normal cardiac output is 4 to 8 liters per minute. A small curve indicates a rapid return of the blood to its baseline temperature and therefore a high cardiac output. Think of this like a raging river. A large curve indicates a slow return to baseline temperature, and that's a low cardiac output. So think of that like a babbling brook or a small creek. A flush system consists of a pressurized bag of intravenous fluid and tubing and provides a continuous flush irrigation system that is needed to deliver 3 to 6 mL of heparinized saline per hour in order to maintain line patency and limit thrombus formation. Be sure to assess the neurovascular status distal to the arterial insertion site hourly. The cannula shown entering the radial artery is connected via pressure of non-distensible tubing to the transducer. The transducer is wired to the electrical monitoring system, which amplifies, displays, and converts the pressure wave into an electrical signal. Stopcocks are inserted into the line for specimen withdrawal and for referencing and zero balancing procedures. Potential complications are hemorrhage, vascular occlusion from an emboli, and infection. The nursing assessment is the responsibilities for all lines. Assess the insertion site for infection and assess distal circulation, sensory, and motor function. Additional nursing interventions include to monitor the blood pressure and always assess the patient's condition when monitor alarms sound. Validate abnormal arterial blood pressure against a manual cuff and check the patient's health status before troubleshooting equipment. Change the dressing per institution protocol and discontinue the intra-arterial catheter when the blood pressure is stable. Observe the catheter site after removal. This dicrotic notch represents closure of the aortic valve and represents the beginning of ventricular diastole. When the aortic valve opens, blood is ejected into the aorta, and this forms a steep upstroke on the arterial waveform called the anacrotic limb. The top of this limb represents the peak or highest systolic pressure. After the waveform reaches its peak, it begins to descend. This descent forms the dicrotic limb and represents systolic ejection of blood that is continuing at a reduced force. The lowest portion of the waveform represents the diastolic pressure and is reflected digitally on the monitor. An Allen's test should be performed to check patency of the radial or ulnar artery, especially before an arterial line is placed. If the color returns in less than 7 seconds, it is a positive test. If the color returns in greater than 15 seconds, that is a negative test, and you need to report negative results. The proximal injectate port is the primary port used for obtaining cardiac output via boluses of iced or room temperature normal saline. Because of the risk of inadvertent bolus of potent medications, no vasoactive drug should infuse in the proximal injectate port if it is used for obtaining cardiac outputs. It would be safer to infuse vasoactive drugs through the proximal infusion port. The distal port is a designated port for continuous monitoring of the pulmonary artery pressure and for obtaining the pulmonary artery wedge pressure. Using the smallest inflation volume possible, typically less than 1.25 mL, will reduce the risk of balloon rupture when checking a pulmonary artery wedge pressure. Resistance may indicate that the balloon is compromising the artery. If resistance is felt, the nurse should stop inflation, allow the balloon to passively deflate, and call the healthcare provider. Passive deflation should be used to avoid damage to the balloon. The balloon should be completely deflated to avoid a continuous wedge, which could lead to a pulmonary infarction. The balloon should be inflated only long enough to obtain a stable reading. The pulmonary artery wedge pressure is a measurement of pulmonary capillary pressure, which reflects left ventricular and diastolic pressures under normal conditions. A normal pulmonary arterial wedge pressure is 4 to 12. A permanent wedge waveform is an indication of catheter migration further into the PA artery, causing an occlusion. An immediate intervention is needed to prevent a pulmonary infarction. The PA diastolic pressure and the pulmonary artery wedge pressures are indicators of cardiac function and fluid volume status. Monitoring the PA pressures allows therapeutic manipulation of preload. Measurements are obtained as follows. Pulmonary artery at end expiration. Pulmonary artery waveform pressure is done by inflating the balloon with only enough air until the PA waveform changes to a PAWP waveform. The balloon should be inflated solely and for no more than 4 respiratory cycles or 8 to 15 seconds. Potential complications of a PA catheter: infection, pneumothorax, air embolus, could be from a disconnection, thrombus, ventricular dysrhythmias, pulmonary infarction, and pulmonary artery rupture. The balloon rupture can be from overinflation. Never inflate the balloon beyond the balloon's capacity, which is usually 1 to 1.5 mL of air. Another potential complication is particle embolus or the catheter coils. The last complication is that the PA catheter cannot wedge or catheter displacement causes a permanent wedge. Complications of an MI are dysrhythmias, heart failure, pulmonary edema, cardiogenic shock, thrombophlebitis, and pericarditis. Interventions in the acute stage is place the patient in a semi-Fowler's position, administer oxygen, nitroglycerin, antidysrhythmics as prescribed, and assess the cardiac and respiratory status. Thrills are palpable vibrations felt when there is turbulent blood flow through the heart or in the blood vessel. Remember, you feel a thrill. You hear a bruit. A bruit is the sound created by turbulent blood flow in an artery. Use the bell to hear a bruit. Auscultating a bruit in an artery is not normal and indicates pathology. A murmur is the sound caused by turbulent blood flow through the heart. It occurs when heart valves are stenosed, cannot fully open, or insufficient or regurgitant, cannot close completely. Relevant information includes the position in which the murmur is heard best, such as sitting and leaning forward, the timing of the murmur in relation to the cardiac cycle, such as systole or diastole, and where on the thorax the murmur is heard best. Mitral stenosis. Assess for dyspnea, orthopnea, rumbling apical diastolic murmur, or pitting peripheral edema. Mitral valve prolapse. Assess for fatigue, atypical chest pain, palpitations, syncope, or systolic click. Mitral insufficiency or regurgitation. Assess for dyspnea, orthopnea, dizziness, signs of right ventricular failure, pitting peripheral edema, and high-pitched systolic murmur. A systolic murmur and palpable thrill would be expected in a patient with mitral regurgitation. Aortic stenosis. Assess for dyspnea on exertion, angina, syncope, orthopnea, and harsh systolic crescendo, decrescendo murmur. Can also see chest pain or pain occurring with aortic stenosis that is caused by cardiac ischemia. Also, a systolic murmur and thrill are expected in a patient with aortic stenosis. Aortic regurgitation. Assess for dyspnea, orthopnea, angina, tachycardia, and blowing decrescendo diastolic murmur. Hypotension in patients with acute aortic regurgitation may indicate cardiogenic shock. The nurse should immediately assess the patient for dyspnea or chest pain. Tricuspid stenosis. Assess for effort intolerance, fluttering sensations in the neck, cyanosis, decreased cardiac output, peripheral edema, and rumbling diastolic murmur. Tricuspid insufficiency or regurgitation. Assess for signs of right ventricular failure, ascites, pleural effusion, peripheral edema, and systolic murmur at left sternal border. Tricuspid valve prolapse is an abnormal protrusion of one or more of the leaflets of the tricuspid valve into the right atrium during systole. This allows the backflow of blood into the right atrium, leading to tricuspid valve insufficiency and heard by systolic murmurs. The most common cause of tricuspid valve prolapse is not primarily valve abnormality, but rather the dilation of the right ventricle and the tricuspid annulus. Pulmonary stenosis. Assess for dyspnea, syncope, signs of right ventricular failure, ascites, and a systolic thrill felt at the left sternal border. Venous thrombosis is associated with the inflammatory process. After surgery, patients should avoid sitting for long periods because of the increased stress on the suture line caused by leg edema and because of the risk for venous thromboembolism. Phlebitis is vein inflammation associated with invasive procedures such as IV lines. Deep vein thrombophlebitis is more serious than superficial thrombophlebitis because of risk for pulmonary embolism. Elevate the affected extremity above the level of the heart and avoid using a knee gauge or pillow under the knees. Do not massage the extremity. Venous insufficiency results from prolonged venous hypertension. Varicose veins are distended, protruding veins that are evident and appear darkened and tortuous. Left-sided failure presents as primarily respiratory symptoms including orthopnea, cough, adventitious breath sounds, tachycardia, and dyspnea on exertion. Crackles that are audible throughout the lungs indicate that the patient is experiencing severe ventricular failure with pulmonary congestion and needs immediate intervention such as diuretics. Right-sided failure presents as primarily systemic symptoms including jugular vein distension, dependent edema, ascites, and hepatosplenomegaly. When the patient is lying flat, the jugular veins are at the level of the right atrium, so a JVD is common but not a clinical significant finding. JVD is an expected finding when a patient performs the Valsalva maneuver because the right atrial pressure increases. A JVD that persists when the patient is sitting at 30 to 45 degree angle or greater would be significant. Pulmonary edema presents as pallor, dyspnea, orthopnea, and large amounts of blood-tinged mucus and diaphoresis. Pulmonary congestion and tachypnea suggest that a patient may be developing heart failure, which is a complication of a myocardial infarction. A cardiac tamponade. The patient should be placed in a critical care unit, administer IV fluids as prescribed, prepare the patient for a pericardiocentesis, and monitor for recurrence of a tamponade following the pericardiocentesis. Pericardial friction rubs are heard best with the diaphragm at the lower left sternal border. The nurse should ask the patient to hold his or her breath during an auscultation to distinguish the sounds between a pleural friction rub and pericardial friction rub. Rubs are not assessed by palpation. The pain associated with pericarditis is caused by inflammation, so nonsteroidal anti-inflammatory drugs like ibuprofen are most effective. Opioid analgesics are usually not used for the pain associated with pericarditis. Paroxysmal nocturnal dyspnea is caused by the reabsorption of fluid from dependent body areas when the patient is sleeping and is characterized by waking up suddenly with the feeling of suffocation. Aneurysms are abnormal dilation of arterial walls caused by localized weakness and stretching in medial layer or wall of the artery. The types of aneurysms are fusiform, saccular, dissecting, and false. Symptoms of having an aneurysm include pain extending to the neck, shoulders, lower back, abdomen, syncope, dyspnea, tachycardia, and cyanosis. Visible pulsations of the abdominal aorta is commonly observed in the epigastric area for thin individuals. This could be considered a normal occurrence in a very thin elderly person. An aneurysm could cause a sudden sharp or worst ever upper back pain. This could be consistent with a dissecting aneurysm, which will require rapid intervention. The nurse must document abnormal findings such as bruit, pain, or hypotension associated with the pulsation. The patient would probably get antihypertensives to help maintain the blood pressure within normal limits to prevent strain on the aneurysms. Postoperative interventions for surgical resection or excision of an aneurysm should be to monitor the vital signs and peripheral pulses distal to the graft site. Limit elevation of the head of the bed to 45 degrees. Strict intake and output. Assess incisional site for bleeding, signs of infection. Instruct the patient not to lift objects heavier than 15 to 20 pounds for 6 to 12 weeks, and instruct the patient to avoid strenuous activities. Thoracic aneurysm repair is done with the aneurysm exposed and excised through the thoracic cavity. The interventions postoperatively are similar to an abdominal resection. A thoracic repair may require monitoring of a chest tube, monitoring respiratory status, and encouraging coughing, deep breathing while splinting the incision.